Okay, well, thank you very much to the organisers for inviting me to speak today about targeted therapy and asthma. I'd like to start by just highlighting the fact that asthma is a heterogeneous disease and the implications this has for therapeutic efficacy, and then move on to look at specific examples of targeted treatments, which will focus predominantly on Th2 targeted treatments, as this is where most of the evidence exists currently. So the clinical syndrome of asthma is characterised by three key components which contribute to airway dysfunction, namely inflammation, airway remodelling, and bronchial hyperresponsiveness. Now, these three features don't occur in all patients to the same extent or in terms of their severity, and it's not surprising, therefore, that we find a great deal of heterogeneity clinically when we see patients, and this is manifest in many ways. For example, through severity and type of symptoms, through propensity to exacerbations, triggers for exacerbations, and of course treatment response. And there's increasing evidence that this clinical heterogeneity is determined by pathological heterogeneity, and this is most evident to date with respect to airway inflammation. And to highlight that, this slide shows the number of eosinophils in the airway epithelium and submucosa in steroid-naive asthma. This is old data. Many trials have shown the same. And overall, in the asthmatic subjects, shown by A here, then the number of eosinophils are increased when you compare them to healthy controls. And it's this sort of data that led to the idea that asthma was really a disease driven by airway eosinophilic inflammation. But when you look at the data more critically, it's clear that there are a number of patients here who actually have eosinophil counts that are no different from healthy controls. And this doesn't only apply to mild asthma, but is also evident in severe asthma. So this work from Sally Wenzel in 1999 identified two groups of patients with refractory asthma, one with persisting airway eosinophilia and subbasement membrane thickening. And subbasement membrane thickening really is a marker of having eosinophils present. And there were another group in whom eosinophils were notably absent, and basement membrane thickening was also absent. Now, this has important implications for your response to corticosteroids. So this is a study from Leicester by Mike Berry in 2007, and we took patients defined as eosinophilic or non-eosinophilic based on their sputum eosinophil count, and we biopsied them. And we looked at pathological measurements in the airways, including the number of eosinophils and subbasement membrane thickening here. And the eosinophilic patients, shown in orange, had significantly higher numbers of eosinophils in the airway mucosa when compared to non-eosinophilic patients or healthy controls, though again, quite a lot of variability. And again, it was this group in whom subbasement membrane thickening was also evident. When we took these patients and we treated them with inhaled corticosteroids, then the non-eosinophilic patients, shown in green, had absolutely no response to mometasone in terms of either methacholine, PC20, or quality of life here, whereas those patients who were eosinophilic had significant improvements in both airway hyperresponsiveness and asthma quality of life. So the key message here is that patients with eosinophilic asthma have a much better response to corticosteroids than those who are non-eosinophilic. So asthma is clearly a heterogeneous disease clinically and pathologically, as shown here by looking at inflammation. So there's clearly a need for better phenotyping and endotyping if we're going to identify new targets which we can target more effectively. So to try and identify phenotypes with an Elsevier asthma clinic, we performed this cluster analysis. You've seen this slide a couple of times today. And we also had a primary care cohort. The difficult asthma cohort is shown in blue, the primary care in orange. And the predominant cluster that emerged from this, we've got eosinophils here on the x-axis, symptoms on the y-axis, is that they're a concordant group of patients who you'll recognize from clinic are usually early onset, atopic. And generally, the worse their eosinophilic inflammation, the worse their symptom control. But there were also some interesting further clusters, particularly this group in the bottom right-hand corner, who had a lot of airway eosinophilic inflammation, not so much in the way of symptoms from day to day, but nevertheless prone to severe exacerbations. And we have this group in the top left corner who are non-eosinophilic, but really troubled by a lot of symptoms. and overlapping here with an overweight group as well. So a key question then is, if we do identify these clinical phenotypes, does this help with patient management? And I think the answer is definitely yes. And to highlight that, I first just need to recap this study from Ruth Green in 2002, where she took patients with severe refractory asthma and followed them for 12 months, and they were split into two treatment arms. One followed standard guideline treatment with escalating treatment based on symptom control, whereas the other group were targeted based on their sputum eosinophil count. So if sputum eosinophils were still present as the study went on, then steroid treatment would be escalated. If they were normal, it could be reduced, and if airway inflammation was controlled, then additional symptoms were treated with add-on therapies. And she showed a marked reduction in exacerbations in the group in whom sputum targeting was used, both reduced exacerbations and reduced hospital admissions. So what was interesting was we then went back to these patients from this study and we looked at which clinical cluster they fed into to see whether clinical cluster would predict their response in this study. And if we look at these patients who are eosinophil predominant here, then really all the signal from this study was from this group of patients. So if you look at the exacerbation frequency, this was approximately 10-fold less in this group of patients. Yes, some of them ended up on oral steroids to control their eosinophilic inflammation, but for clear benefit. If we look at the group in the top left-hand corner with a lot of symptoms who are non-eosinophilic, then the results were very different. So this group of patients had a lot of exacerbations. In the clinical protocol, in spite of escalation of corticosteroids and addition of oral steroids, they continued to exacerbate. The patient in the sputum management group didn't improve, they still exacerbated, but nevertheless we were able to reduce their dose of inhaled corticosteroid without any harm and prevent them going on oral steroids. So what this tells us is that in this eosinophil predominant group, measuring airway inflammation allows us to titrate our corticosteroid therapy appropriately to reduce exacerbations. In the symptom predominant non-eosinophilic group, measuring inflammation at least allows us to down titrate corticosteroids and prevent overtreatment and therefore prevent harm. And of course, if you've identified that your patients fit this concordant group and you've shown that their eosinophilic inflammation is a marker of their symptoms and related to their symptoms, then of course once you've shown that you could manage them based on symptoms. So I'd like to move on now and talk about molecular heterogeneity, and particularly Th2 high versus Th2 low disease. Now Th2 cytokines are undoubtedly important for some patients with asthma, and they have many relevant biological effects to asthma. So I've got mast cells and T cells here as sources of these cytokines, but eosinophils, innate lymphoid cells and so on can all produce Th2 cytokines. And we know that IL-4, IL-13 are very important for IgE production. IL-4 and IL-13 are important for epithelial activation, myofibroblast dysfunction. IL-4 and IL-13 are reported to increase hyperresponsiveness. And IL-4, IL-13 and IL-5 are important for the recruitment, subsequent survival and activation of eosinophils. So obviously highly relevant molecules. Now this slide shows IL-4 expression, again in steroid-naive asthmatics, epithelium, submucosa. And as with the eosinophil counts, you can see overall the IL-4 expression is significantly increased. But again, there are a subgroup of patients who actually don't have IL-4 expression above that seen in healthy controls. So if we were going to target IL-4, we would probably suspect that these patients might not gain much benefit. And if we look at correlations between IL-4 expression and eosinophils in the tissue, we've got epithelium here, we've got submucosa here, these are the eosinophil graphs, then there are significant correlations between IL-4 expression and eosinophil numbers in both the epithelium and submucosa. So the more IL-4 expression you have, the more eosinophils you have. And conversely, if you don't have eosinophils, then really you don't have ongoing IL-4 expression. So this begins to create this concept of Th2 and Th2 high and Th2 low disease. Now others have gone on to look at this using more sophisticated methods, and this paper was published in 2009 by Prescott Woodruff. And they used gene arrays to examine gene expression in epithelial brushings from patients with steroid-naive asthma. And they found that the three most upregulated genes in asthma were serpin-B2, CLCA1, and periostin. And so they developed this IL-13-4 responsive gene signature, as they called it. What was interesting was, though, this wasn't elevated in everyone with asthma. It was elevated in about 50% of the patients. So these are the positive patients, but a significant number of asthmatics here are negative. So about 50% of patients appear to have this Th2-related gene signature. Again, they showed also that the presence of this gene signature correlates with eosinophils. So these are BAL eosinophils, so those patients who are Th2 high. They had significantly increased numbers of eosinophils in the BAL, although again, not everybody. And in parallel with this, these eosinophilic patients were the patients who had subbasement membrane thickening. So does this predict response to treatment? Well, I think you can begin to guess this now. And indeed, these patients who were Th2 high are the ones who had a significant improvement in FEV1 over 8 weeks on inhaled corticosteroids, whereas there was no response on placebo and no response in the Th2 low group. So there's a consistent body of evidence obtained through different approaches which shows that a proportion of patients with asthma have Th2 high disease, and it's these patients that tend to be eosinophilic and tend to respond to corticosteroids. So let's think then about targeting these cytokines. If we're going to do this, we want to target the patients who have ongoing activity of these cytokines. And so we need to identify these patients. So we really need some biomarkers which will predict which patients are going to respond, provide evidence that the drug is hitting its target, and we also need to think about what our output is, because we want to measure an asthma outcome which is relevant to the target we're hitting. So it's very important that we pick the right target in the right patient and measure the right outcome, and I'll show some examples of this as we go along. So starting with IL-5, obviously there's a strong rationale for targeting IL-5 in asthma. It's very important for eosinophil biology. We know eosinophils increased in certainly a proportion of patients with asthma in the airways. Eosinophils release multiple mediators potentially relevant to the pathogenesis of asthma. And for many years it was really thought that they were the key driver of disordered airway physiology. So rather disappointingly, early studies of anti-IL-5 therapy were negative. There was absolutely no effect on allergen challenge. There was no effect in severe asthma, though this was a small study. And in a larger study of patients with moderate asthma, again, there was absolutely no clinical benefit. And in this last study, there was, just to show, there was absolutely no change in lung function or beta agonist use or summary symptom scores. So anti-IL-5 was really put on the side of being no use. But the key thing about eosinophilic disease is, firstly, it predicts patients who are going to have exacerbations. And secondly, if you're picking a target that targets eosinophils, then surely you want to study the patients who are eosinophilic, not everybody. So we undertook this study of mepolizumab in Leicester. Pranab Halder was the first author. And we picked patients who had a history of eosinophilic disease and who also had a history of exacerbations. The drug hit its target. There was a marked reduction in blood eosinophils and sputum eosinophils. Although interestingly, no effect at all on exhaled NO, but this is an IL-13 responsive gene, so perhaps you wouldn't expect a response here. And our primary outcome was asthma exacerbations, and sure enough, patients treated with mepolizumab reduced their exacerbation rate by about 50% compared to controls. And this has been confirmed again in further studies of mepolizumab. So here on the right is the DREAM study, where different doses of mepolizumab were all very effective at reducing the rate of severe exacerbations. But again in these studies, anti-IL-5 had absolutely no effect on lung function, day-to-day symptoms, asthma control score, or bronchial hyperresponsiveness. So what this study tells us is that, firstly, eosinophils do actually seem to be very important in the pathogenesis of asthma exacerbations, but they're not important in day-to-day symptoms and the chronic disordered airway physiology. And it also really highlights the importance of picking the right patients and the right targets. So if you've got a drug which targets eosinophils, exacerbations needs to be your primary outcome. So what about IL-13? This slide shows the concentrations of IL-13 in induced sputum in asthma of varying severity and healthy controls. If you take the refractory asthmatics, you can see about half of the patients have evidence of IL-13 in their sputum. So we'd probably predict that it's these patients that are likely to respond to anti-IL-13 therapy and not these. But how do we identify these patients? Measuring IL-13 in sputum is not really very easy and not practical for clinical purposes. So you remember I showed you a moment ago that in steroid-naive asthma, the three most upregulated genes were CLCA1, serpin B2, and periostin. And it was hoped that periostin might be a good biomarker of IL-13 activity because it's secreted by the basolateral airway epithelium and enters the bloodstream. And this has been studied, and periostin certainly does look promising as a biomarker of Th2 activity. So the graph on the left here shows patients with sputum eosinophilia less than 3% or greater than 3%. And those who have sputum eosinophilia have higher periostin levels compared to controls. It's similar for tissue eosinophilia, although the separation is not quite so good. If you divide the patients up as to having no eosinophilia, so negative sputum and tissue, or just positive for one or other, or positive for both, then you start to see better separation when you compare people who have positive sputum and tissue compared to being completely negative. And if you look at the ability of periostin to predict whether you're eosinophilic or not, then it performs reasonably well and performs better than exhaled nitric oxide blood eosinophils or IgE levels, which are fairly useless. So a potentially promising biomarker. So this was the first key study really of anti-IL-13 therapy in patients with moderate to severe asthma. They were treated with lebrikizumab or placebo, and the primary outcome was lung function, which could be relevant for IL-13 because it is supposed to have effects on smooth muscle. So they measured FEV1, and there was a small but significant increase in FEV1 in the lebrikizumab group shown here at the top compared to the controls. So this is about 8% improvement. What was interesting though, if you divided them into whether they were periostin high or low, then really all the signal was in the patients who were periostin high. You had a much better improvement in FEV1 compared to the controls, and compared to the periostin low group who really had no benefit. So periostin here certainly looked promising as a biomarker to select those patients likely to respond to anti-IL-13 therapy. This study wasn't powered for exacerbations, but there were some interesting trends on post-hoc analysis which I think would make an exacerbation study worthwhile. So if patients were classed as Th2 high or low, based on a composite metric, then those patients who were Th2 high had a trend towards reduced exacerbations. Those who were periostin high had a trend towards reduced exacerbations. And those who were Fino high actually had a significant reduction in exacerbations. So certainly worthwhile, I think, doing an exacerbation-powered study. So the conclusions from this study is that lebrikizumab treatment is associated with improvements in lung function when added to existing therapy. And this effect occurs predominantly in those patients who have high periostin levels in blood. So I'll move on now to IL-4. There have not been any trials specifically targeting IL-4 itself, but there have been studies targeting the IL-4 receptor alpha, which it's important to note contributes to both IL-4 receptor and IL-13 receptor signaling. An early study using a variant of IL-4 which blocks the receptor was shown to have beneficial effects on allergen challenge, so whether given by the subcutaneous route or inhaled, there were significant reductions in the late asthmatic response. compared to placebo. And more recently has seen the publication of this study in the New England Journal of Medicine using dupilumab, which is an antibody which binds to IL-4 receptor alpha. And this study was undertaken in patients on corticosteroids and long-acting beta agonists who had a persisting airway eosinophilia. The study was an unusual design. Rather than adding the treatment to existing treatment, if you look at this top right graph, it sort of summarizes the trial design. So there was a period when patients stayed on their baseline treatment and were given treatment or placebo. Then the long-acting beta agonists were reduced, and then the corticosteroids were tapered. The outcome on this axis is exacerbations, although this is probably more accurately loss of asthma control. And you can see in the patients on placebo, not surprisingly, they were symptomatic and eosinophilic anyway, and their treatment was tailed and stopped, and they got a lot worse. It was interesting, though, that on dupilumab, that they fared much better. So it does provide proof of principle that in these patients, that if you remove their underlying treatment, then IL-4 receptor alpha processes are at play. What it doesn't tell us is whether if we add this treatment to existing treatment, it's any better. If it's no better than just staying on an inhaled corticosteroid, it's obviously a very expensive alternative. This dupilumab study again suggested it was hitting its target, so there were reductions in exhaled nitric oxide in the treated group, there were reductions in Th2-related chemokines, TARC, eotaxin 3, and interestingly in the time course of the study, trends towards reduced IgE as well. So the conclusion from this study was that targeting IL-4 receptor alpha can maintain asthma control if you withdraw baseline corticosteroid and long-acting beta agonist therapy in patients who are eosinophilic. One word of note, if you look at IL-4 expression in severe asthma, then this is usually pretty well suppressed. It is in moderate asthma with patients on inhaled corticosteroids as well. So it's quite likely, I think, that dupilumab, if it's working, is probably working mainly through the biological effects of IL-13, and is perhaps likely to compete with that therapy. I should mention omalizumab, anti-IgE therapy. We've been limited really to treating patients with ongoing disease who can show that they're atopic and who have IgE ranges within a certain range so that we can treat them. And we've never known really who to treat, but it seems really that this is also targeting the Th2 group, because if you look at, if you break down treatment responses by FeNO, blood eosinophils or periostin, then the patients with the greatest reduction in exacerbations on omalizumab are those who are FeNO high, eosinophil high and periostin high. So again, we're probably targeting this Th2 area. I should also mention briefly, I think, bronchial thermoplasty. This treatment involves putting a heated probe into the airway and delivering thermal energy, which supposedly destroys the airway smooth muscle. And it's shown to have clinically positive benefits with improvements in symptoms, lung function, reliever use, and perhaps greater benefit in patients with more severe disease. And this benefit seems to be maintained over time, and there's also a significant reduction in severe exacerbations over time in people using, these are mild exacerbations, these are severe, so people treated with thermoplasty in blue have a significant reduction in severe asthma exacerbations. So, to summarize, there are undoubtedly different clinical phenotypes of asthma with different underlying pathological drivers, and one good way of separating patients is whether or not they have evidence of airway eosinophilia. And if they do, then, and they're patients who exacerbate, then they're potentially likely to get a lot of benefit from anti-IL-5 therapy, but this is unlikely to improve day-to-day symptoms or lung function. This eosinophilic area is also likely to respond to anti-IL-4 receptor alpha, anti-IL-13 and anti-IgE. And obviously this Th2 arena is already getting quite crowded. And one of the key tasks we have, I think, is to work out exactly which patients would benefit from which therapy. And of course, we might need to consider maybe some patients might need dual therapy to target different aspects of their disease. The other key challenge is to work out what drives this non-eosinophilic severe disease, because we really don't know what's going on here. And that's a big challenge. But perhaps for the moment, these patients might be offered some hope by thermoplasty to at least reduce some of their airway dysfunction. Thank you very much.
Thank you, Professor Bradding, for your excellent presentation. And please, Mario Polverino.
According to your last slide, phenotype, mine is a general question about the phenotype. We are discussing always about phenotype by clinical data, phenotype by cellular, by score, but this is a perspective for the future therapy, gene therapy, anti-receptorial therapy, anti-chemokine. But now, with only two drugs, bronchodilator, according to Leo, bronchodilators and anti-inflammatory drugs, how much useful is now the phenotype classification?
Well, I think in terms, as I showed you, I mean, we regularly monitor sputum eosinophils in our difficult asthma clinic, because it is very useful for knowing whether you should really keep trying to push your corticosteroid therapy and whether patients should go on oral corticosteroids, or whether really you shouldn't be. If a patient's non-eosinophilic, you're not going to gain anything by bumping up their corticosteroids. All you'll do is make them sick. So I think there it's very helpful. And I think some of these treatments, no, they're not licensed yet, but hopefully they won't be far away, because I think they will offer some real help to our patients. And we need to be able to target them when we do use them. I mean, obviously we already use anti-IgE, and again, that could be, you could target that based on whether or not they have markers of Th2 disease activity, and probably, use it more appropriately in many patients.
Professor Fabri, go ahead with your question.
Yeah, thank you. Thank you, Peter. You properly highlighted the different results obtained. For instance, the most striking on anti-IL-5 until they did not phenotype. And I have two questions, actually, related to the later studies that you presented. One is the anti-IL-13. That you presented as promising, and apparently there is an IMPRESS paper on severe asthma by the network in the US that has been totally negative on patient-related outcome. It's a different molecule, but it's a little discouraging. On the other side, you presented the dopilumab that was astonishing to most of us for its striking effect. Was it a design issue, or do you think that the data is real? Because it was positive, strongly positive on a patient-related outcome.
No, I don't think there's a problem with the data, but it was a slightly unusual study design. Rather than adding it to existing therapy to see whether it adds anything in these patients who we can't control with standard therapy, they actually took patients off their therapy, and of course patients taken off their therapy got a lot worse. I agree, it was striking that they maintained control with dupilumab. Though it was a short study, it was 12 weeks. We don't know what happened if you went on longer. So a bit of caution there. But in terms of proof of principle that IL-4 receptor alpha is important for a lot of people with asthma, I agree. I think it was very interesting. What we don't know, though, is whether, if you left them on their normal treatment, whether it would add anything extra, or had those pathways, that were dupilumab sensitive already been suppressed at baseline on corticosteroids. So I think there's a lot more work needed there. But I mean, I agree the results are striking, certainly.
Only very short questions, please. And before, I would like to add a very short comment to Leo questions, because Leo, I think that these differences that you highlighted can be explained on the basis of the different mechanisms of these two drugs, lebrikizumab and dupilumab, because lebrikizumab targets only IL-13, and IL-13 and IL-4 are very redundant, overlapping cytokines which share basically very similar effects. Dupilumab targets the alpha chain of IL-4 receptor, which is shared by both IL-4 and IL-13. So it's possible that dupilumab blocks all the IL-4, IL-13 signaling pathway, whereas only targeting IL-13 or only IL-4 may have only partial effects. I think that this can be an interpretation. So, very short questions, please, Gaetano.
I think the design of the dupilumab study has been very clever, because you remove the ICS blocked the expression of IL-4 receptor alpha.
You have the interpretation. Thank you. Oh, no.
Very last and very short question, please.
I have a short question. We are using in a subset of asthmatic patients, severe asthmatics, cheap macrolides. The question is, in your scheme, where do the macrolides potentially fit?
Yes, I didn't talk about macrolides. There's no really good evidence regarding macrolides, although there are some studies and sort of sub-analyses of studies suggest that patients who are non-eosinophilic might get some response from a macrolide, and so they would go in the top left-hand corner if I was going to use them.